Good afternoon. Thank you. Thank you. Can folks in the back hear me? No? All right, we're going to try again. We don't have a mic. The good news is we don't have a mic. The bad news is I have a big mouth, so you're going to have to deal with that for just a few minutes here. Just a couple opening remarks as we get settled in. We're a few minutes behind schedule, but a lot of folks are coming in, probably due to the weather. So thank you for making it out here on kind of a crappy day. We really appreciate it. This is a very important subject for us to be working on. We're very pleased with the Governor Sununu's efforts around the substance use disorder program and being able to host that up here as one of the regional hubs. So we're very pleased. My name is Bob Nutter. I'm the president of Littleton Regional Hospital, and I'm pleased to be with you today. To my side is Jarrett Stern, and he's our executive who's in charge of this project for Littleton and for Androscoggin Valley Hospital as well. So we appreciate Jarrett here administratively pulling this together with our partners with DHHS. Beside him is Lars Nielsen. Dr. Nielsen is the medical director for the program at Weeks, and without Weeks' support, which is a sister hospital of North Country Healthcare, we would not have been able to stand this up as quickly as we have. So we're incredibly grateful to Dr. Nielsen and his support with taking their program up there and helping to facilitate the program we have here at Littleton. Beside him is Dr. Duffy. Ed Duffy is the CEO of North Country Healthcare, interim CEO right now, and he's here to answer any questions as well. So he's the parent company of Littleton Regional Hospital and the 4 other hospitals in the home health agency in this area. I do want to thank Governor Sununu. This is a great visionary effort on his part, working very closely with Commissioner Myers through the last 3 or 4 months in order to stand this thing up has been a real gift, I think, for this community. I'd love to see all the support we have here from our fire, rescue, EMS. Thank you all for making it out on this day as well. Katja Fox is also, I believe she's on the phone with us, and our partners down at Dartmouth Hitchcock, who are an integral part of this. So you'll be hearing from them as well. We'll turn the microphone up as much as we can up front so you can hear. If you can't hear well, we're going to do our best to get out there, but we don't have a microphone we can tap into this. So we'll do our best for you. Again, if you have questions at all about anything as we run through the presentation, we welcome those questions to come up and we'll be happy to answer those. So with that, I'm going to turn it over to Jarrett Stern, and he'll say a few opening remarks.
Thank you. Thanks, Bob. Welcome, everyone. If you can't hear me, I have the same problem I guess Bob has, that I'm very quiet and nobody can hear anything I'm saying. Thank you for coming out on this snowy winter day. It was, the weather's less than ideal, but the turnout is impressive. So thank you. Again, I just wanted to say thank you to our partners at Dartmouth, at the state, Weeks, which I'll be talking about in a little bit. I just wanted to give a little bit of history as to how this program came to be, what it is, where it came from, and where it originated from. The state of New Hampshire received a federal grant to deal with the opioid crisis, which is becoming a major problem nationwide, but in certain states in particular are facing a little worse than others. New Hampshire is one of those states. So the governor had applied for a grant from the federal government, was awarded the grant. It's a $42 million grant over a 2-year period to be divided up among the state how he saw fit to deal with the problem the best he knew how. So he asked his folks at the Department of Health and Human Services, where Katja Fox is the lead on that side, and I pointed to her at the speakerphone like she's sitting here, but she's here virtually. So the state decided to go with a hub and spoke model. Now, it's not a unique model, but our model is a little bit different than it's being used in other states. The closest state that there's a similar example is Vermont, but ours is much different than theirs. It's much better. So the hub and spoke model involves 9 hub care stations or places where the care will be dispensed, and those were strategically placed around the state so that people could access care within a very reasonable amount of driving time. except in the North Country, because we have unique geographical constraints here that others don't face down south, i.e. we have a sparse population and a vast geography, so it's hard to get everybody to the care they need within a short drive. So the two grants were awarded to Littleton Regional Healthcare and Androscoggin Valley Hospital for the two hubs. Now, those hubs are allowed to contract with spokes, which are basically subcontracts from the main hub to provide the services that are required for the community to deliver the care that is needed. We being both hubs, contracted with Weeks Medical Center, and Weeks had been involved in this space for about the past 2 years, and they're one of our sister organizations within North Country Healthcare, so the choice was obvious that we would partner with them to provide the care at the hub, the core services as they like to call them. There are other services that are not the core services that we will be looking to contract with spokes, but what we wanted to do was get our feet wet. We're now 7 days into this. We opened up on January 2nd because January 1st was a holiday. We're dabbling into what we need and what we don't need. So we wanted to get a feel for what each community needs. The nice thing about this model is that each community can customize the plan based on their individual needs. So clearly the needs up here in the North Country may be different from the needs down in Manchester or in Concord. So that the customization allows the flexibility to do what we need to do. I guess at this point, I will turn it over to Katja from the Department of Health and Human Services to say a word on behalf of the state. Katja, if you don't mind, could you give the state's perspective and comment on behalf of the Commissioner of Health?
Absolutely. So thank you, everyone. Thank you for allowing me to join by phone. I'm a wimp, and I'm sitting in Wolfboro, so I consider myself a southerner, and the snow was just a little too much for me to travel. So
Katja.
Thank you for allowing that.
Hey, Katja, this is Bob. Could you speak a little bit louder, please?
Sure.
Thank you.
Let me take it off speaker and see if that helps.
Okay.
Katja,
Let's
we
see
have
if
a
that
full
helps
room
at
here,
all.
so please.
Okay. I may have to jump off because I'm eagerly anticipating my plow guy to come, and I hear he's on his way. So, but I did want to, first of all, thank Bob and Jarrett, who the state has been working directly with. By the way, I am Katja Fox, and I am the director for the Division for Behavioral Health, and have been working very closely with the commissioner and the governor, as well as with the hospital executives to make this happen. So thank you, Bob, thank you, Jarrett, but more importantly, thank you to everyone who's in the room, because what's really important to make this happen is that we all have to dive in and we all have to respond collectively. And so as we've been preparing for this over the last 90 days or so, what has been most impressive is the response that we've received from Littleton and Berlin, because you were already well poised to take this on. It is new, but it's not new for you to work together. So we really appreciate that and appreciate your input and your questions, because that's only going to make us better in how we go about doing this. As mentioned, the state did receive the federal grant, and we are using it in a variety of ways. The core is the hub and spoke model. And so, as described and will be described what the hub services are, there also are very critical providers that are part of what's called the spoke system. And that really is the backbone of where services happen and how individuals get the services that they need. So while the hub is serving as a centralized point to give people the simplified version of how they can access services, where they can call 211. They don't have to call 6 different numbers and find out they have to call a different number. They're able to call 211 and get a transfer and be able to speak to a clinician about their needs. And this goes for family members as well. So we're really excited about this. We have had other funding, as I said, $8.8 million of the 22.9 is for the hubs per year, and the rest is all going into community service providers for various programs and services to really expand our capacity to be able to help individuals with opioid use disorder. And the question has come up, do all of these services only apply to individuals who have an opioid dependence? And what our response is that first of all, the hubs, people should not feel like the hub is not for them unless they specifically have an opioid use disorder. All individuals who have a substance use disorder, no one's going to be turned away. The type of service, the type of data collection that happens is going to vary depending on whether they have an opioid use disorder, but we don't want anyone to think that this is not for them. So with that, we are using this as an opportunity to build the infrastructure that we see is going to be critical to not only addressing opioid use disorder, but other social issues and clinical issues that people have in your community. So again, to reiterate, Governor Sununu really is the mastermind behind this plan, and he really emphasized that he did not want individuals in Manchester to have a different experience than those in Berlin, and vice versa. So he made sure, and he actually took out a map himself and plotted where he thought that it was most critical to have a hub available for individuals. So again, thank you all for being here. We have state staff who are on the call. We will answer your questions, but really we think this should be a regionally driven project and regionally driven initiative and program. And we look to the folks in Littleton to be able to answer those questions about the nitty-gritty operational details. Thank you.
Okay. Thank you, Katja. I guess next we'll jump over to Christine Spring, who is representing Dartmouth Hitchcock. One of the I guess we would call them the spokes that the state contracted with on behalf of all the hubs is after hours. Our clinics are open from Monday through Friday from 8 to 5 p.m. But what happens after hours? Crises are not restricted to during business hours. So Dartmouth stood up a program that will allow 211 to integrate with them and triage these patients either urgently or emergently to get the care they need. So I've asked for the person who is in charge of coordinating that program to talk a little bit about what happens after hours, and then we'll jump into what happens during the hours when I introduce Dr. Nielsen. So Christine, do you have a moment to speak?
Yes, thank you very much. I'm sorry I couldn't make it directly today, but it took me so long to get to Lebanon, I didn't feel like then attempting to get to Littleton. So thanks for having me, and I hope everyone has safe travels home.
Christine, could you speak a little louder?
Yep, I'm looking up at the microphone. Does this help?
No.
Maybe I'll stand up by my microphone and see if that helps, and I'll turn the volume up. Okay, so as Jared mentioned, Dartmouth Hitchcock is providing the after-hours service. So at 5 p.m., when the clinics and the hubs close, if a phone call comes into 211, which is the starting point for all calls and services, 211 will then make a warm transfer to the DH clinician that's on call for the evening. And the clinicians that we have in this pool range from licensed clinical social workers or mental health clinicians, PhDs, or even some of our psychiatrists are participating in the call. So we've got one person on from 5 p.m. to 8 a.m., and then we have a backup person on call as well, so that if there are two calls that come at the same time, we would be able to address both at the same time. If it ever gets to the point that we have 3 or 4 calls happening at the same time, we'll have to refigure out our staffing, but this is what we have for now going on. In the past week that we've been live, we've had on average 2 to 3 phone calls per night, per shift, We're also covering on the weekends. And the calls have ranged from a mom calling about a family member looking for help, or people calling directly for themselves looking for help. And what our clinicians are doing, if it's the person calling for themselves, is really trying to help them get through the evening and making sure that they're safe and comfortable, and then giving them their options for what they can do at 8 o'clock in the morning when the hub opens. The plan is, if in the scenario of somebody calling and they just can't make it through the evening, we would help them connect them to resources that are open in the middle of the night, probably being an emergency department. But what we're still working on is collecting all the resources for the state, working with 211 to really make sure we have a good sense of all the different options for the people available during the after hours, so that we can help them get connected to the right services at that time. So really at the highlight is we're trying to make sure we can help people get through the evening and then know exactly what they can do and what's best for them first thing in the morning when the hubs open back up. So with that, I'll let you ask questions, or if there's other things you think you want to hear about.
Any questions?
How many phone calls are they getting after hours?
Christine, how many phone calls are you getting currently after hours?
Right now, we're getting about 2 to 3 phone calls per shift. So a shift being 5 p.m. to 8 a.m., or on a weekend, it's about 8 a.m. to 8 a.m. So that's what we've seen in the past since January 1st.
Sir?
Alan Clark, Fire Chief in Sugar Hill. So all my experience with opiate overdoses never take place in the morning. And so I'm just curious if there's any consideration of maybe modifying your hours. One of the reasons why the safe stations in Manchester and Nashville are so successful is because they can simply walk in any time of the day. And don't think because we're in the North Country we don't have an opioid problem. And don't think because you live in a rich town that you don't have an opioid problem. And so it's a real problem. And I would think with all the money that's been thrown at this, that maybe you could look at changing the hours so that I don't think you need 24/7. But these people aren't, at least my experience, and I've had, fortunately more saves than anybody would expect from coming from a small town. These aren't morning people.
Thank you. I guess it's just a jumping off point for the clinics to start. We've been open for exactly a week. We're just getting a feel for the needs of each community. I would never say we're going to rule out extended hours. It's a very reasonable thing to look for. Financing is one of the constraints that we look to. But I would say just getting started, we have to assess what we're dealing with first and then make a data-driven decision based upon each hub's needs and patient demands. So thank you for bringing that up.
And I would also just add to that, we are aware of safe stations being open later, and in different parts of the state, like down in Nashville and Manchester, we're aware of services that do run later in the evening. Like Jared just said, we're at the starting point of this, so we're in the process of working with the hubs and with 211 and understanding what currently is available after hours so that people can get actual help and start their MAT if that's what makes the most sense in the after hours. But right now, we're at the starting gate still.
And Jared, Mike, will you repeat the question so we can hear on the phone as well?
Oh, I'm sorry. The question was, have we considered extending the hours of the clinics later in the day or or weekends to accommodate people who have more urgent crises that are off hours? We're going to have a question and answer period at the end. I don't want to, if these are directly for our Dartmouth partner, that would be absolutely fine, but I wanted to, please.
My question is, if they're going to refer them to the emergency room, which happens all the time anyway, is there already a protocol in place so they're not just showing up and we are gonna all wing it as to what we do with them.
Well,
I'll address that in a minute.
yeah, this program is not designed to just refer to an emergency room. There are clinicians on the phone that are actually assessing the person's current state and their needs at the time. It's really not just a simple pass-through to the emergency room. It's much more complex algorithm that they're dealing with based on a licensed individual and an individual on their phone. So it's a really nice program that we're starting in the state. So that being said, I wanted to introduce Dr. Lars Nielsen, who's the medical director for both hubs.
Good afternoon, everybody. My name is Lars Nielsen. I'm the medical director and the prescriber for the hubs at Littleton and at AVH. As I go through the program, I think a lot of the questions that have come up will be a little bit more answered and/or can stimulate more discussion. So with the hub and spoke model, a lot of this has been said, but particularly the stuff on the phone was hard to hear. So the federal government issued grants to the states to combat the opioid crisis. New Hampshire adopted a hub and spoke model where there are 9 hubs throughout the state that will work with other organizations throughout their area to help with the problem. The goal of this is to reduce opioid deaths, and there are thousands of people who die of opioids every year in the United States. We want to enhance treatment options that are available, and right now in the North Country there aren't a lot. Now there's more than there was a week ago, and as we grow and expand, we will continue that. And we want to improve the overall health of our communities. And with that, with people who have the substance use, there's a lot of other comorbidities that go along with that we will deal into. So each hub has a region that they cover, and the Littleton hub is basically a little bit of Coos County, but mostly Grafton, and covering a number of the communities that surround us. So the physical location of the hub in Littleton is on River Gun Lane, right off of Lower Cottage Street. And that site was chosen for a number of reasons. There wasn't really space here at Littleton Hospital, but also with this location being really close to town and walking distance, it's easy for people to access who often have transportation issues. People can walk in, people can call. So the staffing, the clinics are going to be open, as we said, 8 to 5 Monday through Friday. And they will be staffed with a counselor who is trained in substance use disorders to help people deal with the issue and make the transition into recovery. There's also a medical assistant who will help with the medical care and with the intake of the patients, as well as a case manager who will help with providing a lot of the other needs, transportation, housing, employment, and all of that. The hubs are really not meant to be acute care stations. So really, if somebody is, answering the chief's question, somebody really is overdosing, they don't want to go to a hub office. They want to go to a hospital. Now there are in bigger areas the capability of safe stations and other places like that, but the hubs are really not prepared to deal with somebody who's just resuscitated with Narcan. That person really needs to go to the emergency room. So there also is a prescriber, and for the Littleton hub, that's me. And I will be on site one afternoon a week to start with, and as the need grows, we can expand that as necessary. But I am available by phone and by electronic medical record pretty much the rest of the time. We will be prescribing and monitoring the medications that are given, and we're not using methadone. We're using Suboxone, which is a sublingual medication that has 2 different drugs in it. It has buprenorphine, which is a medication that binds to the opioid receptors and stops the cravings. so that people don't have the urge to go through into withdrawal, the urge to use medications for that reason. It also has some naloxone, Narcan, and that's there really to minimize the risk of overdosing. And while it is possible to overdose on Suboxone, it's really difficult because of the fact that there's Narcan in there. There also is little incentive to overdose on it because it doesn't make you high. It just stops the cravings. We use the medication as part of the total treatment plan for these patients. We also use an injectable medication called Vivitrol. And Vivitrol has as advantages that it's a monthly injection, so nobody has a prescription and they don't have any medications at home that can be diverted or abused. It also has a very negative effect if anybody uses an opioid while that's in their system. Severe stomach cramps, muscle aches, headache. People usually only do that once. One of the downsides is that it is an injection, and there are people who really don't want to have needles, even though they'll shoot up. And when you taper people off the medication, there is no capability to taper with Vivitrol. It comes in one dose only. So they have to be transitioned into another medication in order to be tapered. And I'll talk a little bit more about that in a bit. So how do you get into the service? And one of the goals of this is to make it as easy as possible. So we talked a little bit about 211. So 211 is a number that can be accessed from any phone. During the day, you'll be connected to an operator who will then send the call to the nearest hub. And every hub is required to have phones available to take the 211 calls. And then they would get to the staff at the hub who would evaluate and triage and decide what the necessary care for that patient is at this time. Nights and weekends, Dartmouth Hitchcock takes that, and they have on staff a clinical person who may be a social worker or a provider would triage and look at what options that patient needs right away, as well as alert the most appropriate, usually local hub, to get them into the system of the next business day. People can be referred through the hospitals, and we actually have had training of the emergency providers. There'll be more later on this month for how to deal with people who come in and are exhibiting withdrawal signs and symptoms and express interest in getting into treatment. They can dispense, and the grant requires that every hub emergency room have a supply of Suboxone that can be dispensed up to 72 hours worth from there. And they can also call 211 from the hospital to get people into either the hub or through the Dartmouth system. Primary care providers can make the referral. People can self-refer. They can come in either directly, walk in off the street. They can call 211. They can ask their hospital or PCP to help them, set that up. And family. And actually, one of the biggest sources of calls into the 211 system are family members who are worried about their family member, as was mentioned earlier. The community can encourage people, can help to get people into the hub programs. The court system and the correctional facilities also can utilize the services of the hub, the counseling, the case management, as well as the medication treatment. We have several people in our program right now that are they're under court order. And a lot of the people, because they're in a program, can mitigate some of the punishment that comes as a result of their drug misuse. And one thing I want to stop here for a second, and it's really important to consider that we look at this as a disease. It is a disease. It's an addiction. About 10 to 15% of the population is vulnerable to this. And the way to deal with it is to treat it as a medical condition and not as a legal condition. Now, certainly if people are breaking and entering, if they're selling, if they're diverting, that's a legal issue and that needs to be dealt with through the legal. But the addiction itself really is a medical condition. And just as we don't condemn or shut off an obese diabetic because we see him coming out of Dunkin' Donuts, everybody slips, everybody's part of recovery to get through that. So at the Hub, we do screenings. We see, are people really have an opioid problem or other substance use disorder? And it is interesting that there are people who come up to the programs to try to get a prescription that they can sell, and they don't have an opioid disorder. So there's screening that goes on, there's a clinical evaluation, and there's really expansive clinical forms that are required as part of the grant to collect information to decide what resources this person needs and what services they require. There's a counselor. And the real key to recovery is counseling, because people need to deal with the addiction, the physical aspect of it, and that's actually pretty easy. You lock somebody up in a room for 3 days and the addiction's gone. They may still have some cravings, but along with the addiction comes, social problems that when people slip, very often it's because one of the people they used to use with stops by and offers them something. They need to work on, life skills, other relationships. They need to really change their behavior, their personality, and those are things that come from counseling. Everybody gets Narcan, naloxone. So when people, as part of the enrollment, they get a Narcan kit so that if they overdose inadvertently or they're with somebody who does, the Narcan can be given so that they can survive that, get into health care, and hopefully into recovery. And then the medication-assisted therapy. And the medication is really a tool that is used to control the cravings, to try to, part of preventing relapse, so that people can get through the counseling and through the other life changes that are required to be in recovery. It's a tool. And I look at the use of medications as a carrot and a stick. And it's a reward if you go through, if you meet with your counselors, if you go to the groups, if you are, dealing with your legal issues, with your familial issues, all of those kinds of things, you get the medication, and over time, the interval that you need to come in to get a new refill expands out. On the other hand, if people aren't following the rules, if we find substances in their urine that they're not supposed to be, if they're not going to the counseling, if they get arrested, whatever, then we bring it back. So that's the stick part of it. And that's a very effective tool to use to help people get through this. And then the case management. And along with this, pretty much 100% of people have issues with housing, with finances, with insurance, with transportation. That's a big one. We make sure that they have adequate nutrition and food available, a safe place to live, and help people to get through that and connect with the other resources that are required. So we also look at what does this person need, and there are services that go beyond or are different from what we can offer. And there are people who really need inpatient rehab, and there are a number of options, one of which is the Friendship House, which is an agency that we'll be working with. Also intensive outpatient treatment, where typically in a MAT program, the counseling will be an hour or two a week. But some people need more than that. And again, the Friendship House is a program where people go in for much longer intervals, very often half a day or all day. We make sure that everybody is a primary care provider, because a lot of people with substance use have other health problems that need to be cared for. So the primary provider would do the screenings and the treatment for other things that go on. We talked about housing, crisis services. So how do we help people get through a crisis, which happens a lot? Social services, employment, legal and financial issues. We really make sure that everybody has the insurance and other payment systems that are required to get through this. Legal assistance, a lot of these people have legal issues. I had in my panel of the patients that I've been seeing, 3 had court dates this month, and transportation again. So we can see the hub is in the center and has the core services that I've talked about, and around it are the other things: the employment, housing, finance, peer support, primary care, inpatient service, all of those things that are necessary to get people through their addiction and into recovery. So, questions? Yes?
So, this is a great program. I love it. I'm curious, have you been able to address whether or not minors would be able to access the hub-and-spoke model without the parental consent?
Yes.
Fantastic.
So, the question is about minors, and New Hampshire has interesting rules about minors' ability to consent to health care. In many states, there are a number of conditions that can get somebody to their own recognizance. In most states, that's pregnancy. In New Hampshire, it is not allowed there, and it is interesting that a 16-year-old mother can sign a contract on behalf of her child, but not on behalf of herself. There are some exceptions, and one of them is that there is no parental consent required for drug, alcohol, or mental health conditions. So we obviously try to make sure that the parents are involved and aware, and that's part of recovery, but they don't need parental consent to enter.
I imagine the case manager would work with them.
Absolutely. And the counselor. Yes, Phil.
Lars, can you explain the strategies for data sharing, particularly with the challenges with accurate and reliable data in this population, with primary care, with obstetrical providers, with emergency departments, patients are referred?
So my understanding is the details are still being worked out on the transfer of data. We will be documenting in the weak CCW system, but that the records will be transferred to the other providers as needed.
Will there be any exceptions to that, like in terms of consent for sharing of data? And it's particularly important in particularly the prescribing information.
So one of the requirements for entry and at the beginning is that they sign a consent to share that information, because there are specific exceptions for behavioral health issues, but they sign a waiver to allow that to happen. Yes?
Dr. Nelson, just to clarify, it wasn't my comment wasn't related to overdoses. My comment is that the purpose of these hubs, I thought, was similar to that of safe stations. So the reason why the safe stations are so working out so well is because it's a non-intimidating environment. Walking into a fire station is non-intimidating. Firefighters, for the most part, are non-intimidating, and our people seek us out for help. And so the whole purpose of the safe station is when people are ready to try to attack their addiction. Not when they've overdosed, but when they finally come to terms that they want to seek help, that they're able to go to the safe station. And I think that, I'm not suggesting that we should have a safe station concept up here. I just think that you need to understand who your customer is. And I find it a gross misunderstanding of who these people are if you expect them to have to walk into the doorway between 8 and 5, just by thought. But it certainly isn't. I mean, I'm not that stupid to think that those that overdose would be going to the doorway.
So all good points. When you go to facilities where people, talk about strategies and all that. The Weeks model has been that people, the entry to the Weeks program that I think we're going to change is through the counselors. And they get referred to the counselor. The counselor goes through a fairly involved evaluation and decides whether somebody is ready for treatment or not. And if you look at the Bureau of Drug and Alcohol System best standards, that is the model that they use, and you get the highest long-term recovery from those people. But obviously, there's a lot of self-selection. A competing model is that you get people into treatment as quickly as possible, and that you can lose an opportunity by missing that, which can come at any time of the 24-hour clock or day of the week. The tool that we have through the Hub program, and this is something obviously that, as Bob Nutter said earlier, that we are, and Jarrett, that we are evaluating and expanding and looking at how we do that. Right now, the entry for that is through the emergency room and the dispensing of Narcan. And one of my roles as the prescriber, and I've already done this, is somebody's in the pipeline getting in, and I give them a bridge prescription for a week. So that helps them to control their cravings during that time while they're going through the evaluation and all that. And if they're really still using, if they're not ready, we don't want to keep giving prescriptions because that just leads to diversion and all the problems that go with that. So we're kind of blending, hopefully, the best of both worlds. Yes?
As a police officer, of course, so as a first responder, we kind of come across folks more often than not before they're ready to actually come to a facility and things of that nature there. So kind of multi-part real quick, 'cause, I mean, it looks like a great list of services that are going to be out there for folks. What is the best way for them to seek these out? Is it for us to say, go to this address? Is it for us to say, contact this number? What is that mechanism in place?
So the question is, what's the best way to enter into? And I think probably the best way is to call 211. That's real easy. Somebody's always there to answer it, and they have the information to get people into the system regardless of where they are.
Any particular topic they need to say, I need assistance with, or just call 211 and explain their circumstances?
Yep, just call 211.
Okay. Part two, so they come to seek treatment there. What's a realistic timeline from coming to the facility to when services start?
So services start immediately.
Okay.
The initial evaluation and the screening starts immediately. The process takes a long time. It's a several-hour process to get through all of the screening and the forms and all of that. It doesn't have to be done immediately. And we do have the capability where if somebody really needs, again, some medication treatment while they're going through that, that is something that the system will provide.
Hey, Lars, can I what's great about this program, and Lars has described it, but the bottom line is that treatment starts immediately. That's what's different between the great program that Lars has run in Lancaster, and that they do all over the country, and this program. It's absolutely immediate treatment. There's 4 or 5 places in the country where they have this model already. It's been tested, it's been prospective studies to see how it works, and Lars has obviously correctly described that the best way to do it is the first way he described, where people self-select into it, they're ready. But this gets a fair amount of success.
Mm-hmm. Absolutely. And by offering both models, we can really meet the needs of the biggest number of people. And people may come in and they go to the ED, they get their initial prescription, they come in, they start with the process, and they decide they're not ready. But they may not be ready right now, but they've got their foot in the door, so that later on, when they are ready, it's going to be easier for them to get into it.
Okay, awesome. And my last question, payment for the services they're getting, and is there a cap on the number of patients the program is ready to take on?
So the questions were payment, and some of the services are billable and some aren't. The counseling is billable, my provider services are billable. The work that's done by the case manager and the medical assistant is not. The grant pays for their salaries. Part of the case management is getting people, if they don't have health insurance, because the treatment and the medications are very expensive. We do have some ability to help financially, but we also help them to access the Medicaid or the Affordable Care Act programs that they're eligible for. And one of the good things about that is those programs, once somebody is accepted into them, do go back 90 days. So, and they will reimburse people for, or agencies for services that are rendered that either haven't been paid for or the individual is paid for and can get reimbursed.
Do you foresee a cap on the amount of patients initially that you're looking at? Or?
So we don't. You know, I know I was a little bit nervous that there might be a flood. There has not been. I suspect that after these forums, there'll be more because there's more awareness. Right now, I have one patient in the pipeline at Littleton and two at ABH. So I anticipate that will grow. I have a panel of about 45 in my program at Weeks. We could easily do that here. And then, you know, we'll expand the time as necessary. Yes?
In other places, I don't know at Weeks either, if somebody comes into the emergency room, who's gone to an overdose, has been given Narcan, are CRSWs being implemented in the emergency room?
So the question is, when people come into the emergency room with an overdose, are they being connected with recovery coaches? So there's a training program that leads to certified recovery, I don't know what the SW is, support worker. And actually all of the staff have to receive that training, and actually the staff at both Littleton and ABH is going to be doing that the next 2 Mondays and Tuesdays. We have been working with the partners, and actually North Country Healthcare Consortium is one of the agencies that has a lot of the CRSWs, and we're working on a program to have them available and on call. Right now that's not totally up and running yet, but as we get going with this, there should definitely be more availability. Phil?
Are we following data, or going to follow data on, for instance, like prescriptions out of the ER or referrals from the ER, and then what percentage actually follow up with the program, or is your data going to be confined to people who've engaged at the hub level?
So I know for the program, once they get to the hub center, that we will start collecting data on that, and there's a very detailed list that we have to do initially, I think at 3 months, 6 months, every 6 months thereafter, and upon discharge from the program. Yep. In terms of getting from other facilities like the ER, I don't know about that, but that certainly is something that we can. And there is a prescription monitor, so.
But there's no prescriptions written in the ED.
Right.
So
Dr. Duffy is saying
let's get that out. There are no prescriptions written in the emergency department.
Yeah,
Dispense.
they just dispense.
It's dispense, right.
Yeah, we'll do that. We'll follow that. I think it's
Just for everybody, not only for the docs and the nurses here, but for the public to know that, police and fire and rescue.
And again, that's up to 72 hours, so, but just enough to get them till the next business day. So if somebody comes in on a Friday, they're going to get 72 hours worth. If they come in on a Sunday evening or any weekday evening, they're going to get just enough for 24 hours to bridge them over. Steve?
Is there a process to define referring out from the hub to the spokes?
So, no. So the question is there a process? And we're really just now, I mean, this program's been going a whole week. And the grant process through the state really has, got started about 90 days ago. So we've done a ton of work with this, and everybody who's been involved. And I should have at the beginning thanked the people that work with me, Rona Glines, who's the Vice President of Physician Services, Christine Fortin, who is the manager that's been doing a lot of work with the setup of the program and the facilities, Shauna Delworth, who's one of our LADACs, who really has worked to set up the counseling part of it, Lori Collins, who is the caseworker for all this, really have done a ton of work to do this. But we are just barely creeping. And, as we go forward, we'll be developing more spokes. And so with other agencies, as well as with other communities. Good questions, everybody.
Dr. Nielsen, do you want to just address pregnant women?
So, Jared is reminding me to talk about the, that there is a subset of the program to deal with women with opioid disorders while they're pregnant. And we actually have been working with the OB providers here at Littleton to get them in. I have 3 pregnant women in my panel right now. There also is a grant that Dartmouth has to work with pregnancy, and Coas County Family Health has a program to work for that more in the Berlin catchment area. But we are working with the pregnant women with substance use, because one of the major problems is neonatal abstinence syndrome. So the babies get addicted if their mother is while they're in utero. And there is, a life-threatening condition that can happen as they withdraw. And I know that the nursery here at Littleton is experienced with dealing with that. There is much less of an issue with people that are on buprenorphine, Suboxone at the time of delivery. There is some issues that go with the newborns, but it's much, much, much less severe than if they're on heroin or fentanyl or OxyContin or one of the opioids. Yes?
What is the mechanism between the various centers to communicate with patients? We have a largely transient population much of the time. They go from one area of the state to the next. Is there a mechanism that you have a shared database that you can double check as to whether somebody's getting, aside from the PMP?
So the question is, as patients travel around, because a lot of these people are very transient in terms of where they're living and what kind of situation they're in, is there a mechanism to share data? I'm not aware of any formal mechanism. There is, people are filling prescriptions for medications. There is a database that can be accessed, and we do access on every patient before each prescription to make sure that they're not getting multiple prescriptions from multiple sites. And certainly if somebody presents at another community and the patient says that they have gotten treatment at another place, we would send records with a release. And I know actually one of the people in my panel is moving to Tennessee next week, and we helped her to establish care in her new location, so that when she gets there, she'll be ready to go.
They don't have to go through the whole process all over again?
So the grant does require that each hub go through a lot of the intake process, so some of that aggravation would still have to occur, but it can be expedited greatly by getting the information from another hub. All right. Well, thanks for all your great questions.
Thanks, everyone. Just wanted to ask Dr. Duffy to come up and say a few words on behalf of NCH.
I just want to take this one moment to really highlight the power of the 4-hospital and home health agency system coming together. Dr. Nielsen is an expert in this. He's obviously able to answer all questions and understands this completely, but he's actually been doing it. And he is a partner at Weeks Medical Center of Littleton Regional Healthcare and Androscoggin Valley Hospital within NCH was available as an internal resource for us to build this program. And actually his entire team at Weeks, it's not just Dr. Nielsen, I think he'd be the first to tell us that. His entire team in the program they've built in Lancaster is extremely important, and it's almost kind of part of the plan, but we never had the foresight to think that this was going to be something we would need this soon. But anyway, this is one of the benefits of affiliation, and I thank Dr. Nielsen for all his work. Jared also, with high-level executive capabilities, was able to step in and for Bob Nutter and for Mike Peterson at AVH help build this program. And Jared was also an executive in NCH at the time, and he's done a great job. It's really going to come down to the two facilities and all the spokes actually to make this thing happen. Bob's people at LRH do a fantastic job. He does a fantastic job, and he has the support of his board, and I hope the community. So I thank you for coming out. I'm not wrapping it up now. This is not my meeting, but I appreciate all you coming out, and thank you.
Thank you, Dr. Duffy. That was very kind words, and we appreciate it. If there are no more questions for the group, we're going to hang around for a few minutes. If you want to approach us privately and ask private questions, I'm available for administrative questions. Dr. Nielsen for obviously clinical questions. Dr. Duffy, if you could stay around and address any questions related to either the system or emergency medicine access. Does that work for everyone? Thank you very much for
Thanks for coming out.
Really appreciate it.